Welcome to this explainer. Today we're taking a highly detailed medical blueprint and translating it into a definitive guide on esophageal cancer. We'll be moving precisely from epithelial biology all the way down to major surgical excision, unpacking the exact pathology, clinical presentation, staging, and surgical treatments of this really complex disease. Let's get right into it.
Here is our clinical workflow for today. We'll start with an overview and major subtypes, move into pathophysiology and disease pathways, clinical presentation, diagnosis and staging, staging investigations, and wrap up with treatment and surgery.
All right, Section 1, Overview and Major Subtypes.
The major take-home message right off the bat is that adenocarcinoma and squamous cell carcinoma, they are two entirely different beasts. I mean, they have completely different origins and anatomical locations. Adenocarcinoma typically pops up in the lower third of the esophagus from columnar epithelium, and it's highly prevalent in the UK and Western countries. Squamous cell carcinoma, on the flip side, arises in the upper and middle thirds from squamous epithelium, and we see this far more often in developing countries.
Now, notice the striking difference between normal squamous cells and that metaplastic columnar pathway. This illustrates a vital clinical concept for us. Cancer doesn't just develop randomly. The exact histological type of cancer a patient gets depends entirely on which specific epithelial cells undergo malignant transformation. When you understand the normal histology, the disease patterns instantly make sense.
Moving right along to Section 2, Pathophysiology and Disease Pathways.
So adenocarcinoma doesn't just arise suddenly out of nowhere. It actually follows a very ordered, predictable biological sequence. It kicks off with chronic gastroesophageal reflux disease, or GORD, leading to repeated acid injury. This triggers Barrett's esophagus, moving into intestinal metaplasia, then progressing to dysplasia, and ultimately culminating in adenocarcinoma. This sequential biology is exactly why clinical surveillance of Barrett's esophagus is absolutely critical.
But unlike adenocarcinoma, squamous cell carcinoma tells a different story. Here, native squamous cells transform directly into carcinoma. Factors like smoking, alcohol, and nitrosamines cause repeated injury and chronic inflammation. This drives up cellular turnover, leading straight to squamous dysplasia and finally squamous cell carcinoma. The absolute key difference here, Barrett's esophagus is completely absent from this pathway.
So what's really fascinating here is that while the specific risk factors totally differ between the two cancers, with obesity and GORD driving adeno and smoking, alcohol, and achalasia driving squamous, their ultimate mechanism is literally identical. Both of these pathways are driven by persistent epithelial injury. That injury forces cellular turnover, which basically allows oncogenic mutations to stack up and drive malignant transformation.
Let's jump to Section 3, Clinical Presentation and Symptoms.
Think about this mechanical progression for a second. We go from normal swallowing and a nice wide lumen to a larger tumor where solid food starts getting impacted, and eventually to an advanced tumor causing near-complete obstruction where even liquids get blocked. This timeline, progressing from solids blocking to eventually liquids blocking, is one of the absolute strongest clinical clues we have of a mechanically obstructing esophageal malignancy. As that tumor grows, the symptoms a patient presents with fall into two very distinct categories. On one hand, you've got symptoms arising directly from the mechanical blockage, things like vomiting, regurgitation, dysphagia, and odonophagia, which is that incredibly painful swallowing from an ulcerated tumor. But on the other hand, we see constitutional or systemic symptoms. These come from the biological effects of the cancer itself, including progressive weight loss, cachexia, that's severe tissue wasting, and cancer-associated anorexia driven by inflammatory mediators. Now, when local invasion happens, the clinical picture gets significantly worse. Hoarseness can occur, and that's usually when the tumor invades the left recurrent laryngeal nerve as it loops beneath the aortic arch. We also look for melena, or dark sticky feces, which happens through chronic tumor ulceration and slow upper GI bleeding. These specific signs are a massive red flag. They warn us that the tumor has spread beyond the esophagus, often indicating a higher stage and a much smaller window for curative surgery.
Right, onto Section 4, Diagnosis and Staging Principles.
Our gold standard diagnostic workflow requires a very specific sequence of detective work. Upper GI endoscopy gives us direct visualization of the tumor, but just seeing the mass, that is not enough. Only by taking multiple biopsies can we establish the definitive tissue diagnosis. The histopathology confirms if we're dealing with the malignant glands of an adenocarcinoma or the keratinizing squamous cells of a squamous cell carcinoma. And honestly, knowing that is absolutely required before we can even think about planning treatment.
While that biopsy tells us what the tumor is, the TNM staging framework steps in to answer how far it's actually spread. Staging is basically broken down into 3 crucial questions. T asks, how deeply has the tumor invaded the esophageal wall? N asks, are the regional lymph nodes involved? And M asks, are distant metastases present in organs like the liver or lungs?
Which leads us perfectly into Section 5, Detailed Staging Investigations.
To answer those TNM questions, first we look at endoscopic ultrasound, or EUS. Because the EUS probe is literally placed right inside the esophageal lumen, it can distinguish the individual microscopic wall layers way better than any external imaging technique out there. This incredibly high resolution makes EUS the absolute best tool we have for local T staging, determining depth of invasion, as well as checking nearby regional lymph nodes for end staging.
Next up, we evaluate distance spread by comparing the anatomical focus of a CT scan of the chest, abdomen, and pelvis with the metabolic focus of an FDG PET CT. So the CT detects structural liver or lung mets. But here is where it gets really clever. Cancer cells have exceptionally high glucose metabolism, right? So the PET CT uses a radioactive glucose analog that those cancer cells eagerly gobble up, lighting up metabolically active, hidden disease that a standard CT would completely miss. By combining anatomical CT with metabolic PET imaging, we massively improve our ability to spot distant metastases.
Finally, for lower esophageal tumors, we utilize diagnostic laparoscopy. A patient might look perfectly operable on all those advanced scans we just talked about, but direct laparoscopic inspection of the peritoneal cavity gives us the ultimate final safeguard. It acts as a sort of clinical plot twist, identifying tiny, occult peritoneal metastases that imaging simply cannot see. This prevents us from putting a patient through highly invasive, non-curative major surgery when they already have microscopic spread.
And that brings us to Section 6, Treatment and Surgical Management. Treatment pathways decisively split right here. The big takeaway is that surgical intervention depends heavily on the tumor stage, the patient's overall physiological fitness, and the total absence of metastatic disease. Early localized disease pushes a patient down the curative pathway. Advanced disease, however, moves a patient toward non-curative systemic chemotherapy and palliative symptom control. Now, for those on the curative path, the gold standard procedure is the Ivor-Lewis esophagectomy. The surgeon first resects the diseased esophagus and the proximal stomach. Then, we actually use the remaining stomach as a replacement conduit. Why? Simply because its excellent blood supply and natural length allow us to safely pull it up into the thoracic cavity and reconstruct the GI tract with an intrathoracic anastomosis. However, this kind of major surgery is definitely not without its risks. The most feared postoperative complication by far is an anastomotic leak. If that surgical joint fails, it allows highly dangerous saliva and gastric contents to leak out, which contaminates the mediastinum and causes a massive, life-threatening mediastinitis. This exact risk is exactly why technically perfect surgery has to be paired with perioperative chemotherapy. We have to target any unseen microscopic residual disease to ensure the absolute best long-term survival.
We've covered some incredible ground today. As we integrate this entire framework into one mental map, from progressive dysphagia to EUS staging and the Ivor-Lewis procedure, I want to leave you with a final thought to chew on. If cellular biology completely dictates whether a patient gets a squamous or an adeno, how might targeted biological therapies eventually rewrite this entire surgical workflow? Thanks for joining me on this explainer, and I'll catch you next time.